Hello, my name is Claude Blanc, and I am the publisher at New City Press, the publishing house of the Focolare movement. This webinar is sponsored by New City Press and Living City, and the topic, as you well know, is clarity and perspective in time of COVID-19. So welcome to all of you, in particular welcome to our panelists, Dr. Quyen Ngo-Metzger and Dr. Clare Masters. And give me a minute to introduce them. Dr. Clare Masters is a third-year fellow in the Division of Infectious Diseases at the Northwestern University Feinberg School of Medicine in Chicago. Dr. Masters received her undergraduate degree from Stanford University and her medical degree from Washington University School of Medicine in St. Louis. She returned to Chicago for her internal medicine residency at the University of Chicago, during which she also completed a fellowship in clinical medical ethics at the McLean Center. Mary Clare, welcome. Dr. Quyen Ngo-Metzger is a professor in the Health Service Science Department at the Kaiser Permanente Bernard J. Tyson School of Medicine in Los Angeles. She teaches and mentors students and junior faculty in prevention, population health, health disparities, and evidence-based medicine. Previously, she was scientific director of the U.S. Preventive Service Task Force, which has developed and maintained over 130 clinical practice guidelines for preventive services. This work involved reviewing the most up-to-date research results and determining which services are most clinically effective. The guidelines provide a scientific basis for insurance coverage of preventive services nationwide. Dr. Ngo-Metzger brings over 2 decades of experience studying and improving the quality of care. Her research focuses on prevention, the social and cultural determinants of health, implementation science, healthcare systems, and evidence-based practice. She has published more than 85 original peer-reviewed articles and received numerous awards in recognition for her work. So, Quyen, welcome.
Thank you.
So, during this webinar, you, the participants, may have questions. You can use the Q&A box at the bottom of your screen to type in those questions. And after both presentations, Suzanne Jensen, who is the editor of Living City, will be facilitating the Q&A session. So feel free to enter your questions while the presentations are being presented. So let's start with Mary Clare, with Dr. Mary Clare Masters. Mary Clare, if you want to share your screen, and you have the stage.
Sure, thank you. Thank you all for having me here today. As Claude introduced, my name is Mary Clare. I'm currently an infectious disease fellow at Northwestern in Chicago, and I'll be focusing on ethical and humanistic challenges for healthcare providers during the COVID pandemic. I don't have any financial conflicts of interest, and I should disclose that the views that I'll be sharing are my own and don't represent my employer. My only disclosure is that my neighbors are doing some construction, so I apologize if there's some background noise. So today I'll talk briefly about healthcare providers' duty to treat during a pandemic, as well as ethical challenges in clinical decision-making that are specific to COVID-19 that providers have been facing, and then to describe a bit of the experience of a patient in isolation for COVID treatment at the hospital or at home, and how we can support them beyond their medical treatment. So the idea of healthcare providers' duty to treat is kind of an ancient concept. So, humans have faced plagues throughout history. In its first code of medical ethics, the American Medical Association had this quote, which I thought was kind of relevant, about when pestilence prevails, it's the duty of physicians to, I can't actually see the whole quote, to face the danger and to continue their labors for the alleviation of suffering, even at the jeopardy of their own lives. But throughout history, physicians' response to pandemics and epidemics has varied over time. And during times of ancient plague, even dating back to Galen, physicians have sometimes fled from cities for their own health and protection. Looking back at pandemics more recently in the 20th and 21st century, perhaps the last pandemic of influenza in 1918, saw that most physicians did adopt this duty to treat, that even at great risk to themselves and high risk for infections, they continued to care for their affected patients, and very few refused to treat patients. There's been kind of an ideological shift throughout the 20th century. Around the 1950s, kind of the idea of duty to treat became less pervasive in the medical community. The nature of infectious diseases was better understood. There were more tools like vaccines and antibiotics, and perhaps the risk of the physician's personal health was not seen as paramount. This idea of duty to treat came back into focus in the 1980s with the HIV epidemic. Overall, healthcare workers during the HIV epidemic had a low risk of actual transmission of HIV, but because of a number of issues, a lot of providers did refuse to provide care for persons with HIV. And this spurred a lot of discussion of what physicians' obligations are to their patients and serving all patients. In more recent epidemics, so the first SARS in 2003, healthcare workers faced really high risks of infection in healthcare settings. And in some of those situations, healthcare workers did stop reporting to work. And then more recently with the Ebola outbreak in 2014, for the most part, this is a very infectious agent. In the US, it was quite limited. So the physicians who cared for those patients were mostly volunteers. So duty to treat was not as big an issue. But in other countries like Western African countries that were more heavily affected, physicians and other providers faced high mortality rates, lack of protective equipment, and in some of those cases, providers stopped reporting to work, which affected the care of not only Ebola patients, but overall just general health care in those communities. So the question of what is a healthcare provider's duty during a pandemic? And many would argue, and most of the medical associations currently argue, that healthcare providers do have a duty to treat during a pandemic. And this stems from a moral obligation that as physicians, most people go into the profession because they do want to care for people and have that impulse. You can also argue that doctors and nurses that chose to go into this profession knowing that they might be exposed to some risk, and that we're also highly trained with a specialized skill set which others in the community might have. Also, since the public supports a lot of our training, there's a social contract with the public that we're when faced with pandemics and epidemics, we have obligations to individuals in our community to give back from that training and care for communities and individuals. And I think that kind of set of obligations gives you this humanistic picture of the healthcare worker. So this is the classic painting of the doctor from 1981 of the doctor who stayed up all night long with a feverish little girl, his gaze focused entirely on that individual patient while her parents are in the background. And this is kind of the stereotypical or prototypical image of the humanism in medicine, and really what I think many doctors feel is kind of their underlying ethos. In the setting of a pandemic, also as physicians and other healthcare providers have other obligations outside of the hospital and outside of our medical careers. And so the question is, you know, why during a pandemic would people leave the city or have reservations about treating patients? When you're thinking about that in terms of coronavirus, you know, a novel virus that we don't know much about and is highly infectious, especially spread within the healthcare setting. These are some of the issues that come up for providers. So perhaps the biggest concern for healthcare providers is the risk of transmission to your family and other vulnerable close contacts. So many physicians have had to make difficult decisions about whether or not, you know, if they're working in a coronavirus unit, whether or not they stay at their own home or have their children stay at their own home, or maybe if they help care for, you know, a vulnerable older relative, having to isolate from those individuals. A particular concern has also been for pregnant physicians about, you know, with unknown risks, what are you exposing your child to as well as yourself? That leads into the personal risk of infection or severe outcomes. So for physicians who themselves are in high risk categories, sometimes this becomes an issue. So we know that coronavirus disproportionately has severe outcomes in older individuals. So for an older physician, what is their obligation to serve on a frontline coronavirus unit? And then for certain providers who might care primarily for vulnerable patients, so patients with transplants or oncology patients, they worry about their risk of, you know, spreading this infection to other patients. And then a huge issue that has been broadly talked about in the news is the question of whether or not there's adequate protection in place for a physician. So, you know, if you don't have masks or gowns or infection control policies in place in the hospital that are working well, you know, physicians and nurses and other medical staff all face increased risk of contracting it themselves. And is that an obligation that they're obligated to take on? You know, that you could argue, you know, firemen have an obligation to put out a fire, but, you know, if the building is collapsing or incredibly unsafe, should they go in the building, is what some have argued. So I thought this cover image from a recent New Yorker was a nice contrast to this kind of prototypical picture of the physician, of that on the right you have the, you know, more modern medical worker who is working in a busy coronavirus unit, but also has family at home, has other obligations, and is trying to serve the community and protect themselves. And so these are the issues that have had to be dealt with, and that many physicians and other healthcare workers have had to balance in responding to the pandemic, and that we've seen policies come into play to ensure that doctors are protected. Transitioning more into thinking about specific clinical decision making during the coronavirus pandemic. Kind of first just talking about the general principles of medical ethics that we all learn in medical school. So there's these 4 pillars of autonomy, or you know, respect for the individual patient and their desires and values, beneficence, so doing good for your patients, non-maleficence, or doing no harm, and then the concept of justice, or fairness and equity in medical care. Putting this into practice, this is kind of the famous 4-box method of ethical clinical decision making. So when physicians and other practitioners are thinking about clinical decisions and discussing them with their patients, you think about the medical indications. So taking into those, why are we doing this procedure and what are the risks and benefits of a specific therapy or procedure. So that's where those ideas of beneficence and non-maleficence come in. The preferences of patients, so that patient autonomy, the effect of any sort of intervention or decision on quality of life, and that takes into account beneficence, doing no harm, and autonomy as well, and then other contextual features that encompass justice and equity and fairness. And in non-pandemic times, many of the features that guide clinical decision making fall into these medical indications, quality of life, preferences of patients. But in the setting of a pandemic and limited resources, these contextual features and concerns about justice and equity change the nature of clinical decision making and bring in new issues. So just briefly talking through some of the clinical ethical challenges during the COVID pandemic, and there's myriad challenges, but these are just a few of the hotbed issues. Early in the news, there was lots of discussion about if we're faced with scarcity, how should we allocate life-supporting interventions? Things like ventilators, hospital beds, got lots of attention. Physicians in the community saw what was happening in some countries in Europe and New York, where physicians and providers were having to make very challenging decisions about whether or not you would offer life-sustaining therapies to patients, because there just wasn't enough to go around. Thankfully, in many other parts of the U.S., including at my own hospital, that has not become a reality, but was something that was very frightening as we first set into the pandemic. Other questions, especially in my field as working directly in infectious disease, is what therapies should we offer to patients? When you don't have a lot of evidence for any specific therapy, and you don't know, you don't want to do harm, but you also want to do good. Should you be giving therapies when those risks and benefits aren't fully understood or outside of things like clinical trials? And what are the implications for the broader community if you give therapies outside of clinical trials? We've all heard about lots of different medications in the news that have shown activity in some petri dish, and if you put enough of anything in any petri dish, it will do something, but whether or not that's safe for patients or efficacious on a large scale is a challenging question for physicians. And then more recently, as we start to have effective therapies, who do we give them to first? So the first drug to show any sort of efficacy, this medication remdesivir, showed some promise, and we have been giving it to patients, but there's only a limited supply of this medication, and it's expected to run out by the end of the month, and there won't be more available. I think it's been projected until August. So in the meantime, who do we offer this therapy to, and how do we justly allocate that medication? And those have all been difficult questions that we've had to grapple with and have conversations with individual patients and on a larger scale within the hospital about. And then I think one issue that, we talk a lot about the medical care of individuals with COVID and how to protect ourselves at home, but understanding the experience of the patient who is hospitalized with COVID-19 is something that is perhaps not as recognized in the news. and I think is one of the most challenging aspects of the pandemic for clinicians and healthcare providers. You know, caring for these patients in a pandemic setting is very different than caring for any other patient in the hospital, and on a humanistic level is challenging for obviously the patient, but also the provider interacting with that patient. So what it actually looks like in most hospitals for patients with coronavirus is that there are visitor restrictions. So patients are often alone. Family members and loved ones can't come and visit in person because of the risk of transmitting infection. In addition, healthcare providers also limit their exposure to these patients. So, you know, you try to go into the room fewer times during the day to limit exposure and try not to spread the infection throughout the hospital. And as you can kind of see in the picture, some kind of typical protective equipment. Physicians are often wearing masks, face shields or goggles, gloves, gowns. So you can imagine, you know, it really limits the personal contact, that touch and kind of human connection that physicians are used to with their patients. And you can imagine, especially for patients who are older or might be delirious in the hospital, this is even more distressing. And I think one thing that I've heard from patients that's most distressing to them is just the uncertainty and fear of the future. So, you know, we're still learning about coronavirus and not knowing what their outcome is going to be. So, you know, people see these reports in the news where people go into the hospital and never come out. And they share these fears, both patients in the hospital and my outpatients who have had coronavirus and are self-isolating at home are fearful about what the future brings. There was one article that I read from this, he's a famous virologist, Peter Pio. He actually discovered Ebola virus and was very influential with other viruses, but actually got coronavirus himself. And he wrote an article in one of the scientific journals about his own experience being in the hospital with coronavirus. And he mentions, I always had the question going around in my head, how will I be when I get out of this? And that's, you know, something that we're not always able to fully reassure people on, because we don't know all the answers yet. And then that isolation, even when people recover and leave the hospital, continues outside of the hospital until their risk of spreading infection resolves. So people remain isolated in their homes, or if they don't have to go to the hospital, can remain isolated for prolonged periods of time, worrying about their risk of transmitting to their family, sometimes having difficulties with getting their necessities or other needs met. So some of the ways that medical workers have responded to try to foster humanism in caring for these patients. One like small thing that you see commonly is, as you can see in the picture on the right, is that many providers have started kind of posting pictures of their face on their gowns, just so that patients know behind the mask and the face shield who they're actually talking to. But there's been a widespread uptake of, you know, we've always called folks, but using video conferencing to facilitate both, you know, routine and sometimes bigger conversations with patients and their families and their providers. Many institutions have provided additional communication training for the providers who are working particularly in COVID units, because often, you know, these providers are having to have difficult conversations about overall goals with patients and how to do that sensitively. In some cases, there have been compassionate exceptions for things like visitor restrictions. Obviously, that varies by the institution. And then how to support patients even after they leave the hospital. So at our institution, there's a phone monitoring program where somebody calls any patient with coronavirus daily, ask them about not only concerning symptoms, but just to see how they're doing and what concerns they have so that we can proactively address them and connect them with social work resources or other resources that they may be in need of. So that's just a brief overview of some of these ethical and humanistic issues. Just some closing questions for reflection and discussion later on is, what can we do further to support those who are isolated in both in the hospital and in their homes. And with coronavirus, but there's also many other individuals who are isolated to try to prevent getting coronavirus, which I think Quyen will talk about more later. And then I think another important question is how, both physicians and everyone can support and maintain connections with the most vulnerable in the community. Those who have underlying medical issues and have to self-isolate. And then we also know that our communities are disproportionately affected by coronavirus. So things like people who experience homelessness or, particularly the African-American and Latino communities in Chicago have been disproportionately affected by the pandemic. How can we support those who are experiencing this excess burden of coronavirus? And then I think trying to find a silver lining in COVID-19 is that, like necessity is the mother of invention. A lot of this video conferencing, ways to connect with patients, ways to connect with others outside of in person, we've been forced to kind of adopt to handle the current situation. So once coronavirus is, the pandemic is over, how can we carry forward some of these ways that we're staying connected and helping one another to build stronger and more resilient communities in the future? I know for physicians, we are now doing phone and video visits with patients, which have always been a good idea, but haven't been forced upon people. But I think, that may be something that's transformed in medical care because of the pandemic. So with that, I can turn it over to Quyen.
Thank you very much. Thank you so much, Mary Claire. If you have any questions for Dr. Masters, please use the Q&A box and we will answer those questions at the end. Hopefully we will have enough time at the end to answer the questions. Again, Mary Claire, thank you so much. So now I would like to invite Dr. Ngo-Metzger to present her part of the program. Quyen, if you want to share your screen, thank you.
Thank you. So you can see my screen?
Yes.
Okay, great. Thank you. So I'm going to talk about living a resilient life during a pandemic. And I know it's been a pretty rough couple of months for all of us, a pretty rough week for all of us. So hopefully we can discuss a little bit of what, would help us get through these difficult times. Advance slide. There you go. So disclaimer, these views are mine and do not represent those of the Kaiser Permanente School of Medicine, and I also have no financial conflicts. So the objectives of the talk is to explain the differences between healthcare and public health systems. I know it's been very confusing for people where there's infectious disease doctors talking and then there's the public health officials talking. So we're going to just talk a little bit about the systems point of view and how they interact with each other. And then I'm going to talk about the different types of tests that's available for COVID-19 and their roles and their pros and cons and also the timing of the test. Because again, we are still only learning new things about this disease, and the tests are fairly new as well. And then I'm going to talk about the importance of staying connected to friends, family, and community during this difficult time, because I think that's really what helps our mental health. So discussing the differences between healthcare and public health. The mission of healthcare delivery systems is to design, deliver, and coordinate healthcare services for individuals seeking care. So I'm sure that we all have seek care in some kind of healthcare facility, and we're pretty familiar with this model of care. Public health systems is less familiar to most of us, partly because a lot of times the public health systems occur in the background and nobody's paying any attention. The mission of the public health systems are to assure that as a collective community, the conditions or the environments in which people live and they can be healthy while they live their lives in the community. Some of the functions of public health is to assess and monitor community health status, to diagnose and investigate community health problems and hazards, to develop policies focused on keeping the community healthy, to inform, educate, and mobilize community partnerships to identify and solve health issues. Sometimes community public health departments also enforce laws and regulations of public facilities to protect the health of the public, and also to evaluate community health services. So I just want to talk to us about systems thinking, and we all play different roles in multiple different systems that we're a part of. I'm a doctor, as is Dr. Masters, but most of us, we're also patients at some point in our lives. And we seek care usually in an exam room, usually in a clinic, so either a primary care clinic or a specialty clinic. And then there's also the interprofessional teams that include nurses, medical assistants, lab technicians, others. And they usually exist within a healthcare organization. And even within this healthcare organization, there's the urgent care facilities, there's the emergency room, the emergency department, also inpatient or hospital care, as well as laboratories. And there's this whole thing that we're actually knowing more and more about, which is the electronic health records or the informatics. And they also exist basically to support all of the information sharing. And then, of course, there's different departments and different subspecialists and specialists that specialize in different aspects of medicine. So there's the patient, and the patient exists within a household with their families or their roommates or their friends. And they're within a network, a social network of people that they interact with every day. Could be their coworkers, and then they live in their neighborhood within a community. And then again, as I mentioned, they interact with coworkers at work, maybe go to school and interact with teachers and other students. There's also parks and recreation where we go and collectively use the public space. There's faith-based organizations such as churches. And then there's also nonprofits. And then there's the public services such as policemen and firemen and others who support us. And then there's policymakers, including the politicians and people we vote to help represent us and give voice to our perspectives. And these all exist in the regional, state, and federal environment. And then when there's a need, usually somebody's seeking care, usually it's medical care, and there's issues of access and eligibility. Can you get the testing that's needed? Can you get access to medications? And then there's the patient flow as you're moving around within the system and you're exposed to other patients, other people within the system. How does that all work? But there's always a flow, and it's a difficult system to navigate sometimes because there's so many different types of people that's involved in the system. And then the data goes into the electronic health record or the information system. And that feeds into a separate system that's probably living in the cloud somewhere, but it should be confidentiality and privacy should be maintained. And then there's referrals for a laboratory test. And then the results go back into the electronic health records or the informatics system. And then there's referrals to specialists in different departments, such as ophthalmology or infectious disease or oncology. And that information also has to feed back into the electronic health records. And This is all, it's a giant system that actually needs to communicate to really take care of the patient. And then there's post-encounter care and follow-up that Mary Claire has talked about. So this is the medical care system. With the public health system, it's in a much larger level with the city, the county, the state, and the federal level. And there's usually a Department of Public Health in the local level. So it's the city level of Los Angeles or Chicago or smaller cities. And they take care of the health of the population, of the people in the cities. And they get information from the hospitals, from the private clinicians, private practice doctors, and others that report back to the Department of Public Health regarding some infectious disease or deaths and birth, so that there's a keeping of the records. There's also the health environment that the Public Health Department is in charge of. So making sure that the restaurants are clean and that you're not going to get food poisoning, that the markets are clean. There's housing. There's also places for like massage that it's also clean. And then some places like in Los Angeles, for example, the Department of Health, the Public Health Department also regulates the pools, the public pools, so that all the environment that the whole community lives in is healthy. So there's inspection and sanctions of all these public spaces. And then the Public Health Department also often runs infectious disease clinics and provides immunizations and screening and treatment of infectious disease. And I think that, we go back to the days of tuberculosis and HIV and other diseases that could be spread, including sexually transmitted infections. So that's a lot of time public health departments would run these infectious disease clinics. And then report the disease incidents back to the Public Health Department to keep the records, to see what are the infectious diseases that are being spread in the community in that particular city or county or state. And the Public Health Department provides information, advice, analysis, reports, and then also birth and death certificates to keep track of the health of the population. And then the other policymakers, such as politicians and mayors and governors, use this information to make decisions. And then the Public Health Department advises and influences. But they are just a department, and they are funded just like the police department or the fire department. They're funded by taxpayer dollars, just like the Department of Education or Parks and Recreation. So I think that's where this is really there to serve the whole community. And their budget is out of taxpayers. So I think that the opportunity to get involved is for individuals to make sure that there's a healthy environment for people to live in, and it's paid out of your public dollars, just as the fire department or the police department or the libraries or the parks. So I'm going to shift gear now and talk about testing for the coronavirus, because that's been really in the news, and also it's important that we have really good data. I also want to say that we're only learning, and this is pretty much, the tests are like 1.0 version. It's like your phone. It's still the 1.0 version, and as we learn more about this disease, the tests will become better. So there's two main types of tests. There's the swab for the coronavirus, the actual virus particles itself, and that's usually a swab of the inside of your nose. Sometimes we're actually looking at the throat as well. But there's a high rates of false negative, meaning that you may have the disease, but the nose swab misses the virus for some reason. They didn't swab the right place, and it was missed. So I think that the issue to know is that there may be false reassurance. So that a negative test does not necessarily mean that you are not infected. Because right now, the current test that we have, the current version, which is 1.0, it'll be more accurate as we get better testing. There's a 20 to 30% false negative test. So that you may have the infection, you may be passing it on to others, but the test says you're negative, and you can still infect others 2 to 3 days before you have any symptoms. And on average, the incubation period or the time period may be 5 days. So you may be not having any symptoms, but maybe still be infectious, and the test may be negative, and it's a false negative. But this is what we have right now. But I just wanted to caution people that that the test is not completely 99% or 100% accurate. like we have like the HIV test, where this is like 4.0 version of the HIV test. This test, we're still developing it and we're still refining the test. So there's still a 20 to 30% rate of false negative test. The other type of test that people hear a lot about are the tests for antibodies, meaning that it's actually a blood test that you get, and it's a test if you've developed immunity or antibodies to the virus. So it's not an actual test for the virus itself, or not for the virus particles, but it's a test of the body's immune response to the virus. So antibody tests for COVID-19 detect prior exposure to one or more coronaviruses rather than the virus itself. And again, it does not really indicate active disease or infectivity. So it's not that useful right at the time of infection. It's actually most useful like 10 days to 14 days after you've already developed symptoms. So this is not the test to find out whether you have the disease right away or not. It's more a test that occurs after you've already developed symptoms to see if you actually had the disease. Now, it's unclear whether the currently available tests represent antibodies that will actually give you immunity to the COVID disease. We think it does, but we're not quite sure. It's not been well validated, and there's some potential drawbacks. Again, false negative risk if you're performing too early in the disease course. So again, it's the nose swab that's best for the early infection to actually test for the virus itself. These blood tests are much better if they're done a week or 10 days or 2 weeks after you already have symptoms. And again, you can have a false negative test if it's performed too early in the disease course. You can also have a false positive test because there's possible cross-reactivity with the common cold coronaviruses. So there's a possibility that you have a positive antibodies, but it's actually not for the coronavirus and COVID-19. It's for a common cold flu virus that you've had before. So there's a false positive risk for the test. And again, as I've mentioned before, we're still not sure how long, if you test positive with the antibodies, we're not sure how long the antibodies last or how much protection there is. It's likely that you would have some immunity to the virus for several months or more, but we're still learning a lot more about these antibodies and how protective they are in the long run. So, this is how I think a lot of us are feeling right now, a lot of anxiety, a lot of unknowns. So how do we stay resilient in such a time when so many things are unknown? So I'm going to shift gear a little bit and just talking about, about our mental health and how we can stay connected to each other. I'm going to talk a little bit about the study called the Harvard Grant Study that is one of the longest running observational study that's existed. It started in 1938 and it still continues today. It's been going on for over 75 years, and this is one of the longest studies that we have observing people as they live their lives in the community. The study followed almost 725 men living in the Boston areas from adolescence to early adulthood, and there's questionnaires that they answer throughout their lives. They start studying the young men from all socioeconomic walks of life. Included in this cohort study are Harvard graduates like John F. Kennedy. So there's students who went to Harvard and then graduated from Harvard, as well as boys and young men from the poorest neighborhoods in Boston. A psychiatrist named George Valiant was the original principal investigator of this study. And if you want to know more about the study, there's a great TED Talk done by Robert Waldinger that this link will give that to you. But it really tells all the details about the studies. And as I said, this is the longest study that we have of people, mostly just men, no women here, unfortunately, but living in the community. And the findings, what they found is that the number one thing that affects health is social connectedness, and that social connectedness brings forth joy. And close relationships are equated with health, longevity, and happiness. And in these men, they found that satisfaction with relationships at age 50 are correlated with their health, mental health, and their physical health, and their happiness at age 80. They also found that loneliness is detrimental to physical and mental health. And it's not so much how many relationships that you have, but it's the quality of the relationships that matter. And having close relationships help people feel healthier, live longer, and basically have more quality of life. So I just wanted to bring this up because I think during this time of social isolation and social distancing, it's really important that we all stay connected together and we stay connected to the important people in our lives and the important community that we're part of. So some questions to reflect on and discuss together include, how are you doing right now? Ask yourself, how are you doing personally and as part of a community during this time? What are the different communities that you're a part of, and how do you stay connected to those communities? Also, what activities bring you energy and life and happiness during this very anxious time that we're all experiencing together? And then how do you stay connected to your communities, whether it's your family members who live far away or your family members who live close by, and also your church communities, your workplace and friends and other communities that you're part of. And then I think we could also discuss about how we can best support ourselves, our families, our community, and also the healthcare and the public health systems that may be overwhelmed during this time. So I want to close with some acknowledgement to thank Dr. Gary Ryan from the Kaiser Permanente School of Medicine for his help with the slides, and then Drs. Sanjeev Chopra and Ahmed Azim for some of the ideas for this talk. So thank you.
All right, thank you so much. Quyen, this was really a beautiful presentation. And now it's time for the questions and answer. And Suzanne, take it over.
Yes, so first question was regarding the value of fresh air versus closed ventilation or staying in closed rooms. How is it about the risk to get infected, staying outside or inside?
Dr. Masters, I'll give that one to you since you're the infectious disease specialist.
Yeah, so I mean, I think every week there's another study where they've sprayed some sort of something using a machine and say what size of particles or how far how far they see coronavirus in some sort of simulation. In general, the risk of infection is less outdoors and in fresh air than if you're in a crowded room with other people. But it always depends on your surroundings as well. So if you're in downtown Chicago, outside around many other people outside, there still is a risk of infection. And obviously whenever you're out in crowded spaces, wearing masks can help protect others, as well as give you some protection yourself. Hopefully that answers the question.
Thank you. Another question is about how do indigent and uninsured patients get diagnosed and how are they then treated at city hospitals?
So right now in most cities and counties, it's free. The test is provided for free to people who feel like they may have the disease. Usually at the public health department or a private health department is giving the test and then monitoring. But right now, it's basically, you should not be charged. There are county and local health departments that will actually give the test for free in most places. And a lot of the insurance plans, and I can't speak for all of them, are actually providing it for free as well, because they realize that it's a public health issue, and they're providing that service for free.
There's also
thank you. Another question is regarding, are all the disinfecting sprays used in public places dangerous to our health?
In general, disinfecting is a good idea. It probably depends on which disinfectant spray is used. I'm not aware of any public health concerns about current disinfection protocols that are in place right now. I don't know if you have any other thoughts on that, Gwen.
No, I don't think so. I mean, I think it's mostly, most of the stuff, you know, the Perel that we all use, it's mainly alcohol, like 70% alcohol, like rubbing alcohol. I've told people that you could actually use rubbing alcohol or, you know, aloe vera gel with rubbing alcohol. So it's been, you know, it's things that we've used for a long time. You could use vinegar, bleach, the general household disinfectants that we've used, you know, to disinfect our house for a long time is effective against the virus.
That's good to hear that our disinfecting won't cause any danger to us. Here's another question. As an infectious disease expert, what are some of the characteristics of COVID-19 you find the most perplexing and troubling? What lines of treatment do you find most promising? And can COVID-19 have long-term effects?
So I think some of the unique challenges of coronavirus that we've encountered is that people can spread without having a lot of symptoms, which has made it a challenging infection to control. And then I think the thing that has been most perplexing to physicians is, well, maybe two things. You know, early on, people would talk about how this is just kind of like another flu sort of thing. But a certain subset of patients, you know, some people have pretty mild illness, but we do see this subset of patients that are hospitalized who basically have another stage of the infection. So, you know, typically the people who get sick or very sick with coronavirus get sick about 5 to 7 days after they develop symptoms. So there's usually kind of the first viral symptom, right? That people have kind of general cold and flu symptoms, body aches, fevers, cough. And then some people develop, you know, these very high fevers, very severe respiratory disease that seems less related to the virus itself and more an overreaction of the immune response. And that can happen with other viruses, but is very accentuated in this infection. So that's what's kind of different about coronavirus that had the medical community concerned. And then the extent to which it can affect multiple organ systems. So, I mean, at least in the medical literature and probably in the news every day, it seems like there's some sort of new symptom that they're discovering about, you know, whether it can affect neurologic things or your skin or your lungs or a different organ system. So it is a very widely systemic disease. And in terms of how long-standing the effects of having the infection will be, I mean, I think we're still learning all of that. This is still a pretty new process, and so we'll have to follow people over time to understand that. Anecdotally, I mean, there are things that we know can last a while. I mean, people are often very fatigued after this illness for a prolonged time. Things like the loss of smell and taste last for a while. And then just whenever you get very sick with any illness, you know, you get deconditioned and the effects of those can be long lasting as well. So I imagine we'll see that in some individuals as well.
Thank you. There are a couple of questions coming in right now. This is one for Dr. Metzger. Do you believe public health offices at every level, particularly US Public Health Service, should have additional powers, prerogatives, etc.? And if so, which ones?
I think that probably the local people, you know the local environment the best. And I think that hopefully my diagram showed that everything comes from the local level. It's all the information and the data comes from what's local and feeds back to the county, to the state, to the federal. So they have I think the most, for our local, they're most aware of the local environment. And then, it gets wider and wider and larger to the federal level. But I would say that, that's why it's really important to support your local health departments, because that's where all the data is coming from. The federal level, such, in the Center for Disease Control and Prevention, their data is only as good as the data that's actually being fed from your doctor and your local feeding back to that. And so they have the, they have the infrastructure to analyze and have the research for the whole country. And they're going to talk about the whole country and the whole population for the whole country. But I think as far as, the local environments, that's what, we probably, that data is most accurate to you because that's where you're living. You're not living in another state.
Thank you. Another question regarding nursing homes. Are new regulations coming out to protect the elderly in nursing homes?
I mean, I don't want to speak to that because that's not my area of expertise, but I believe there will be new regulations that are coming out, and it's probably going to be linked, regulations for nursing homes usually have come out of the Center for Medicare and Medicaid because that's the payment for the nursing homes. And I believe that there will be some regulations for nursing homes. And there's always been what Medicare, that's the organization that actually regulates a lot of the quality of care that's in nursing homes.
There is another question also related to the problems of isolation for persons who are living in nursing homes where some members are tested positive. Can you address some of the possible consequences for the residents regarding their mental well-being?
I think that's particularly for nursing home residents, that's a particular concern. People who are in nursing homes are often older or have other medical comorbidities that would make them predisposed to things like delirium and, having regular contact with familiar faces and people that they know well and routines really does improve their health, and having those meaningful connections that Quyen talked about. I think it's a challenging time for administrators in nursing homes too. Most nursing homes are quite locked down currently, not allowing visitors, just to protect residents from the spread of infection. There's staggering statistics about the number of diagnosed coronavirus cases in the US. A huge proportion are from nursing home outbreaks. They're very vulnerable in many ways. And I'm not sure people have come up with great solutions about maintaining social connectedness for residents in nursing homes. That's a problem even without a pandemic, even when people are free to visit. So I think that's a huge challenging issue.
So another question that I think will be of interest for all of us. Could someone who tested positive for COVID-19 and then a month later tested negative be able to get the virus again?
I don't think we know the answer to that yet. Mary Claire, do you think? Good.
Yeah, I think like you mentioned, the testing is difficult. I mean, I think most people presume that if you've had an infection with coronavirus, that you probably do have some sort of immunity. How long lasting that is and whether everybody develops immunity, we don't know for sure. Some of those challenges of I presume when they're saying tested positive and then tested negative, they're talking mostly about the nose swab, because that's not a super accurate test. Sometimes we do see people test positive, then negative, then positive again, and whether or not that's a new infection or just the quality of that test is something that is still being worked out as we get better at our testing.
Unfortunately, we are running out of time, but thank you so much to Dr. Ngo-Metzger and to Dr. Masters. Thank you for sharing your wisdom, sharing your expertise and knowledge. And I'm sure that probably a lot of people still have a lot of questions. If you want to send them to us, we will forward them to Dr. Masters and to Dr. Metzger. Again, thank you so much. Thank you also to all the participants. You will receive an email tomorrow with also some resources in order to continue that information flow. Also, I'm just giving you a preview. Next week, we will have another webinar on racial issues. So I invite you all to participate and invite your friends. So again, thank you very much and have a great day.
Thank you, everyone.